Hello and welcome to today's webinar, Mental Health on the Front Lines of COVID-19, Part 2, a phased approach for support. Today's webinar features ADAA members Dr. Sheila Rauch and Dr. Barbara Kamholz. There will now be a brief moment of silence as I pass the presenter role to our presenters for introductions.
Hi, and welcome back to the ADAA special series on COVID-19 mental health response. I'm thrilled in my role as Senior Advisor for Professional Education to ADAA to be hosting Dr. Sheila Rauch again. As I mentioned, this is part 2 of our series. And to remind everybody about Dr. Rauch's expertise, I do want to mention that she's professor in the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine. She also serves as Deputy Director of the Emory Healthcare Veterans Program and Director of Mental Health Research and Program Evaluation at the VA Atlanta Healthcare System. She's a member of the board of ADAA and also sits on the Scientific Council for ADAA, and she's a fellow of the Association for Behavioral and Cognitive Therapies. The work that we're going to be talking about today, the phased approach, represents collaborative work by Dr. Roush and her colleagues, Drs. Naomi Simon and Barbara Rothbaum. So thank you so much for coming back and talking with us more about this, Sheila.
Thank you. Thank you for having me.
Absolutely. So, let's start at the beginning, of course. Can you give us an overview of the phased approach?
Yeah, so the phased approach for supporting mental health of healthcare workers and others affected by COVID-19, what we're calling the PAC, is an evidence-informed framework for health systems and organizations, as well as for mental health professionals. We really developed this for people to be able to use as we're planning and implementing interventions to care for people through this pandemic. And we wanted to really recognize that the current pandemic is unprecedented in its impact, being worldwide and across all levels of society, some more impacted than others, but still across everything, and also its extended duration. So previous models of disaster response really haven't considered the worldwide impact, as well as that this is going to be a marathon that requires a lot of consideration of how we're using resources and how best to deploy those resources now, as well as over time and into the future as we're continuing to deal with the impact of the COVID-19 pandemic. When we were developing this, Barbara and Naomi and I were really thinking about it as a living document that we intend to update as we as a field learn more about response. And as new interventions are developed or we become aware of other interventions that are out there, we're really wanting this to be something that gets better with time and gets better with other people contributing. And most of what's in here has been around to deal and developed to deal with other issues or other disasters that we've had in the past. And the framework is really intended to provide for the how and the what to use when. It's an evidence-informed approach, not evidence-based, because obviously we haven't been able to run an RCT on something like this pandemic. And it's really intended to connect people to comprehensive resources and really create a comprehensive model instead of just a piece here, a piece there, really thinking about the pandemic over time and across different types of impacts that it has on people.
Now, thank you. You and Barbara and Naomi talk about phases of care and levels of care. Can you describe for us a little bit more about each of those important categories?
Yeah. So phases account for how systems respond over time. So what we're doing during this potentially traumatic event that's really extended and impacting people differently is going to change a month from now, 2 months from now, and a year from now. We're still going to be dealing with it though. So that's part of what's important, is looking at it over time and then looking at the different levels. So the levels really focus on Different people may have minor impacts all the way to pretty severe impacts with job loss, with loss of multiple people in their families. And so that's really what we're intending. So looking at the slides that we have, the phases that we've developed are the initial phase, which is really what we're in right now. So it's where the pandemic is ongoing, where we're having new cases and we're having lots of people impacted, lots of sick people, lots of healthcare workers working with those sick people, lots of people having some mental health reactions, but really not knowing what that's going to be quite yet, because the impacts are still acute at this point. So that's that initial phase where we're fighting the pandemic. And then when we think about the post phase, that's really from that acute exposure to risk. So some people may lose people close to them. Some healthcare workers may have patients that they lose that are particularly difficult. And so that post phase really starts after those key traumatic losses or other key incidents that someone might have that are potentially traumatic. So it goes from that till about the next 3 months after that. And that's the time typically that we're expecting people to really be having strong emotional reactions, which would be normal, as well as experiencing resilience and natural recovery over time, where those things will be starting to decrease over time, we would expect. And then there's the long-term phase, which would be 3 months or more and farther out from there. What's important with these phases with this current pandemic, though, is they're going to be overlapping. So for instance, Atlanta is somewhere in that plateau phase right now as far as new cases, we're hoping. Other places are farther out, so potentially New York is farther out in that plateau, we're hoping. And then other places have not seen all of the impact yet. So if we go out to some of the Midwest and they're projected to have more of the impact towards June or July. So those across our country, the phases are going to be overlapping, and what's an initial phase in one location may be different in another. It's also within an individual that those phases may shift and change. So, and then the levels really focus on the impact of that and different ways that we can intervene to assist based on the different levels of impact. So the first level is system supported level, and that's kind of a general umbrella of providing support resources and other access to support, to community, to positive coping. But it's provided on a system level. So that's either state government or your employer or other groups, churches, those sorts of things getting out there. Then the self-directed level is where people may be feeling that they need additional assistance or a little bit more than what the system is providing. And so they will do some self-assessment of need and decide that they want to do a little bit more. And so then we've got some interventions built in for the different phases for that. But that self-directed level is really for people with mild to moderate distress or functional impairment. If they're at the point that they're imminent risk to self or others, then we would bump that up to, of course, mental health supported, which is our final level, mental health supported brief interventions. And that, again, is there's a little bit of that at each of the phases, but it's directed slightly differently because we are looking more at, in those initial phases, more at a model of the expectation of natural recovery, the expectation that people are going to do better over time. And then as they continue to have difficulties over time, then we would want to do a more intensive treatment or intervention to give them what they need.
So you talk a little bit in your review about how you might shift from one level of care to another level of care. What would you recommend as sort of benchmarks or factors to be attending to and noticing? I'm imagining particularly between self-directed and mental health supported, but across the model, how would you recommend assessing those needs and then acting on those needs?
Yeah, so one piece that's really important is especially in those initial phases, we're really relying on the individuals to do that first assessment. So because our expectation is people are going to be getting better with time, we would expect the individual to reach out for help kind of on their own, and then their significant others may suggest that they may need some support or assistance. For mental health providers working with patients, we're really looking at them assessing for imminent risk. And of course, if there's any risk of harm to self or others, then we're wanting to bump that up to getting to national resources, or if they need to be hospitalized, those sorts of things. But if someone is actually feeling like they're not functioning in their life, they're not able to do their job, we're wanting to bump those people up to start working with mental health professionals as much as possible. But this is also where it's really important to think about this as a marathon and not a sprint. This pandemic is going to be a drawn out stressor for the world. So we want to be making sure that everyone, as much as possible, can have access to mental health needs. And in order to do that, we need to try to focus on, as mental health professionals, giving people the least restrictive or least resource intensive version of care that's going to get them the response that they need. So it's similar to when we talk about stepped care in the VA or in other places of working with patients to do self-directed and see how far that gets them. If it doesn't get them all the way there, then we bump them up to mental health supported and brief interventions. And if that doesn't get them enough, then we bump them up to a higher level of care. But keeping in mind that anytime that a patient is bumped up to that highest level of care, they're going to require a lot more resources. So that means that we would be able to see fewer patients if we're seeing all of them at that high resource level.
And it sounds like at those different levels, it gives the system and individuals also an opportunity to intervene at the earliest possible moment when they start to notice things either at a system level or an individual level.
Right. And again, that's an efficient way for us to use our mental health resources, because if we send everybody, for instance, if everybody ends up developing PTSD and we want to give them the best care that we can offer of PE or CPT, we're going to run into a resource problem pretty quickly, because even before the pandemic, it was difficult for patients to find providers who could do PE or CPT well and have their insurance pay for that. So that's going to just be exaggerated now because we'll have more demand on the system. So we really want to try and use those self-directed resources, use the briefer models, and then bump those people up who are most in need of care. And in addition, as you said, prevent people from getting that far. So if we intervene earlier, can we give them a dose that's a little bit smaller, but that's going to work for them because we caught them earlier.
Great. And so thinking about that earliest level of intervention, that system supported level, can you talk to us a little bit about key targets for systems supported care at each of the time phases? So at the initial phase, the post phase, and the long-term phase. What can our systems do to support frontline medical providers at each of those phases?
Yeah, so the key targets for the system supported levels really across all the phases are focusing on providing for the needs of their identified workers or people if it's a community. So making sure that people, especially initially, that they have enough food, they have a place to live that's safe, they have PPE or other supplies that they need to remain safe over time, they have testing, those sorts of things. In addition, it may involve making sure that people are taking breaks and that their work situations are such that it's supporting their wellness and their health. We want to, especially in those initial phases, we want the system supported levels to be targeting normalization of emotional reactions to stress, because we're all stressed. We've all had huge shifts in our lives, working from home instead of being out as much, having people very sick around us, lots of people very sick potentially. So normalizing that if you're upset in this situation, that's fine, that's okay. And it's good to let yourself feel those emotions and use your social connections to deal with those emotions. And then providing system supported level really focuses on making sure that people have information on resources and how to access those resources. We want to avoid any group debriefing for the early levels or really throughout. And by group debriefing, I'm specifically meaning groups where people are compelled to tell the details of their traumatic experiences. And that's just based on some research that suggests that may actually make reactions over time worse.
And so that's really helpful to give us an overview of those targets. If you were providing advice, hopefully folks who are watching this are going to be administrators in hospitals or other healthcare systems and universities, clinics, and so on. Can you provide some examples of steps that you would advise organizations and its leaders to take?
Yeah, so first of all, I've seen actually a lot of examples across different health systems of excellent ways that they're encouraging wellness and encouraging social connection, even as they're sending people to work more from home. And as people are getting involved in intensive care units, some people who are used to working in that setting and some people who are not, making sure that we're providing training so that people feel comfortable and feel like they're doing things that are within their scope and control. Those are all excellent things that can be done by organizations and by leadership. And then making sure that there are policies in place that support the wellness of staff. So that includes making sure breaks are built in, staffing ratios are reasonable, really reconsidering and considering leave policies and that sort of thing in this pandemic situation where lots of people who didn't plan to be teachers are ending up being teachers of their children at home while they're trying to work from home. And so really being proactive in talking with staff about what are your needs and how can we help address those needs right now. In addition, making sure that there's adequate safety and supplies available so that people can be safe. We want to reduce the spread of the disease as well.
And at the that's really helpful. And what about at the self-directed care? So you talked a little bit about the framework that, say, medical centers or hospitals can provide. For individuals who are on those front lines, what are your recommendations around self-directed care?
Yeah, so people who are on the front lines, the best things that they can do are continuing to engage in self-care, whether that's exercise or talking with friends, finding ways to maintain those connections that mean a lot to you, finding ways to maintain some of your routines that are that can help you feel in control of your life and help you to decompress after difficult days. So maintaining that social support and connection. In addition, once we move out from those initial phases and into the post phase, when you've had specific experiences that may be upsetting to you, there are some really nice ways to start thinking through those memories and processing those difficult experiences while you're still working on your general stress management and realizing that emotional reactions are normal. Even when they're normal, we can help work through them or talk through them or think through them, including thinking through what we feel like went well or didn't go well so that we can move past those memories over time.
And when we were preparing and discussing this presentation, you had also described some specific interventions that medical providers can use. Can you share that with us now?
Yeah, so we have developed with our colleagues at the University of Chicago and NYU. There are a couple of specific things. We have a mask anxiety exposure that's like a 2-page intervention. And the idea there is really we have lots of people who are not comfortable wearing masks. Some of those are people who had panic reactions in the past. Other people, it just feels kind of gross to be breathing your own air and makes them feel more anxious. So that's a nice intervention that's really quick. It's self-directed, but if you're feeling uncomfortable in a mask, that's something that can help. In addition, we developed for those difficult days, we developed a self-directed exposure protocol that's called Making Meaning of Difficult Days. That's really focused on helping talk through and helping you think through your experiences. And that's something you can share with others or not as you feel you would like to. And so that's also included. And all of this is in the framework that is on the ADAA website. So you can see the links are right there, and it's in PDFs that you can print off and look at and use as you feel like you would like. In addition, the third piece that we really developed here is a brief mental health supported assessment and CBT intervention for use in that post and long-term phase. So it's a way for mental health providers actually to work with patients who may be impacted. What are the key areas to make sure you're assessing and really jumping into some brief interventions for reactions, whether it's PTSD or depression or panic.
And so just to review those briefly in terms of the phases, it sounds like the mask anxiety exposure program is really for that initial phase, of course, while we're all wearing masks all the time, and of course, particularly for our medical providers who have a whole different level of PPE use. And then the second two you described, the self-directed exposure for difficult days, and the brief mental health supported assessment and CBT intervention, those are more on the post and long-term phase. Is that an accurate description?
That's exactly right. Yep.
Okay, terrific. And so what about those mental health supported interventions? Can you talk to us a little bit? You've obviously already mentioned 2 specifics. Any other key targets we should be thinking about for mental health supported interventions, again, at each of those phases, initial, post, and long-term? Any other thoughts?
Yeah, so this pandemic that we're all experiencing is really an ongoing life-threatening situation. So I'm used to working with PTSD, so I tend to talk in PTSD language, but really we're expecting lots of different reactions from different people. We're expecting a lot of grief, normal grief as well as complicated grief. And that's going to be a big one coming out of here because we have a lot of sadly, a lot of loss of life and loss of jobs and other things. In addition, panic reactions, PTSD, depression. What's really important, I would say, across the phases here is in the initial phases, I don't know that it's helpful for us to be putting labels on things. We're expecting strong emotions. We wouldn't diagnose someone with depression based on being in a specific stressful situation. We wouldn't diagnose with someone with PTSD based on being in that situation in the moment. So we want to kind of stay away from labels, but maybe look at what are the flavors of difficulty that people are having. And we're expecting there to be guilt. We're expecting there to be fear and anxiety. We're expecting there to be sadness and loss and grief. As we move into that post level, that's where we start to consider potentially putting more labels. I would still be a little bit cautious at that phase because that's really from when someone's starting to feel safe again, or starting to feel like the acute stressor is done and we're now in the recovery phase. And so I would be hesitant to put labels on for a couple of months because you're still going to see a lot of natural recovery. And then as you get in that longer term phase, that's really where we'll be expecting to put more of those labels of complicated grief, of PTSD, of depression, panic disorder, and other issues.
Great. And so one of the things that's very helpful about this phased approach, of course, is the phases and recognizing that there are different needs at different times. In this initial phase, in which most of us are still right in the middle, can you give us sort of do's and don'ts, sort of general tips for providing support and help to providers on the front line, to medical providers on the front line?
Yeah, so I've got my last slide. I believe this is my last slide. Oh no, it's my second to last slide. Some tips here. So for systems and individuals engaging in mental health response, we would really encourage you to ensure those basic needs are met for food, sleep, and lodging. Any way that you can enhance social connection and support for yourself or for anyone that you're working with is good, whether that's through telehealth or connections on Zoom or other means. Provide ongoing support for people as they would like, not in a single shot. So anytime that we're intervening, a single shot tends to drift away or kind of get lost in the sea of stressful situations. So if we're going to work with people, make sure that we can have repeated contacts and suggest things that they can do a couple of times so it becomes more of a habit. Encourage people to engage in past positive coping strategies. Oftentimes when we're under stress, we forget about the things that have worked for us in the past. So we really want to make sure that we encourage people to use those. And then also the flip of that is reducing unhelpful coping. So people who may be drinking more than they usually do because they're at home or other things, or they're under stress, you want to be cautious and potentially suggest that they reduce that. You want to create opportunities for people to share their stories, share their experiences as they're ready and willing, not compelling people, you have to tell me what happened, but letting people tell their stories as they would like, and don't force it. And again, that's a good place where we want to make sure that that's repeated again, because one time is not necessarily going to bring people to the end of their story. But if you let people approach their stories over and over with you, that can be really helpful. And I've already mentioned avoiding group debriefing, and then providing information about accessible mental health resources so that if someone feels like they want more help, feels like they're not living their life in the way that they need to, that they can just go ahead and access those resources earlier.
And so throughout this, throughout our discussion, you've talked at various points about, some self-directed making meaning, talking about what to avoid in terms of group debriefing. The approach also talks about something you all called processing light. Can you talk about how that fits into this framework?
Yeah, so that's built into our self-directed exposure, that making meaning of difficult days, brief self-directed intervention. And the idea of that is that processing light is that as we talk through our experiences, or write through is what we would be doing with this, we're able to think about those situations in a different way. And the intensity of the emotions, the very normal emotions that are connected with difficult memories, can get a little bit less. And when that gets a little bit less, we're able to come to new conclusions, consider things differently. And that can really be helpful for people generally in life. If we feel like our story, our life story makes sense, we're able to move on from that.
So that obviously, conceptually, of course, is very similar to traditional exposure, and I realize that's no surprise here. Can you draw a little bit of a distinction for folks, particularly folks who aren't terribly familiar with traditional exposure? How would that differ from traditional?
Yeah, so one big way that it differs is that this is going to be based on the person saying that they want to do this, or that they're interested in working through these memories now. So that's one very big difference. In addition, this is really focused on being less structured, so it's much more of the naturalistic way that people would approach difficult situations and their memories of difficult situations. And then if they have trouble, we wanted to also provide connection to resources if they feel like they need more than they're able to process it on their own. But basically, in most ways, it would be the same. So you're approaching that difficult memory and all of the emotions that are connected to it. When most people think of exposure therapy, they tend to focus on fear and anxiety. But all of those emotions are important and can be processed. And that's what this self-directed exposure is focused on.
So you've talked a lot about these overlapping constructs of or approaches of making meaning and exposure. Any other thoughts or comments on how this particular stressor and any of its characteristics may be unique for making meaning, and obviously within the context of your model?
Yeah. So just with what we've known so far of the pandemic, we expect that lots of guilt and lots of grief are going to be parts of people's reactions to the COVID-19 pandemic. And one thing that we know is the more that people let themselves feel the emotions that are connected with grief and with guilt, the more that they're able to move through and move past them. So we're expecting that to be a big part of what we as a society are dealing with. The loss of health, the loss of employment, the loss of our, a lot of what we thought was possible in the world or not possible in the world, those things have all changed based on this current pandemic. And the self-directed exposure and other components of this framework, as well as staying connected with people, reaching out to your social supports, those are the things that are going to help us all move through this and come out the other side in a more resilient place.
You know, grief does seem to be a topic, I think, in our society and sometimes within mental health that doesn't get as much attention as other topics. Can you speak a little bit more about how grieving under these circumstances and in general is addressed in your model?
Yeah, so grieving, well, first of all, there are some specific interventions. So I mentioned the 3 things that we had developed, but a large part of this framework is pulling in what's already out there and in the community and has a good evidence base behind it. So there are some specific links and practices that we've connected for grief. The American Psychiatric Association, Dr. Simon worked with a working group of the APA on a couple of grief documents specific to the COVID-19 pandemic, and those are included. So there's lots of specific things to do with grief, but really, as we were writing the framework, grief and fear were the 2 big emotions, big experiences that we're expecting people to have to process. And connecting with friends, gaining social support, finding ways to feel in control of your current life, continuing to exercise, those are all things that are excellent ways to manage grief.
Thank you so much. Thank you for being here with us again and for agreeing to do both of these webinars. And of course, to you, Barbara Rothbaum and Naomi Simon, for developing this and making it so widely available to everyone. I'll remind everybody that it is available on the ADAA website. That's adaa.org. It is free for anybody who wants to download it. And thank you so much. Please be well.
Thank you. Have a good day.
Thank you very much, Dr. Roush and Dr. Kamholz.
Thank you.
If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual conference, and much more. We would also like to invite you to check out more ADAA on-demand webinars by visiting our website, www.adaa.org. On behalf of ADAA and our presenters, we thank you for joining us today.